Good morning, everyone. I'm Marmagkiolis from Florida Hospital in Tampa and the Pepin Heart Institute. We're presenting one of the challenging cases we have done. This is a 63-year-old gentleman who presented with a non-ST elevation MI. He had a history of hypertension, hyperlipidemia, and gastroesophageal reflux disease. He presented to our emergency. He was taken to the cath lab. Diagnostic angiogram showed severe LAD disease, 80 to 90%. There is also diffuse disease in the distal LAD. He was found to have a chronic totally occluded distal left circumflex. In the angiogram, you can appreciate in this view that the LAD is about 90% stenosed. And it's also interesting that there's very few collaterals to the right system. The left circumflex has diffuse tortuous chronic total occluded disease in the distal segment with TIMI-1 flow. Interesting thing about the RCA was very difficult to cannulate. It had it had diffuse disease even at the ostium. That made it very difficult to cannulate, and it had an anomalous takeoff, high anterior takeoff. It made it very difficult to cannulate with the JR4. The only catheter that would allow us to cannulate was a 5 French AL.75 guide. We were able to do the diagnostic test. Therefore, the results of our diagnostic study was anomalous RCA with high anterior takeoff, chronic total occluded, 3-vessel coronary disease, ejection fraction of 30%. Patient was referred for bypass surgery. Patient came back next day. Patient was seen next day in the hospital, and we had another discussion about percutaneous intervention. Therefore, we planned for elective Impella-guided PCI of the LAD, chronic total occluded PCI of the distal left circumflex, and PCI of the right coronary artery. So our plan for our PCI was to place an Impella, place a 7 French sheath on the right common femoral artery, and put an Impella to the left groin. We planned to initially start with the left system, and as there were not much collaterals from the right system, we planned for antegrade only intervention. This is our first shot. We made sure that the Impella was placed in the left common femoral artery rather than below the bifurcation. So this is the angiogram of the left common femoral artery to confirm that our Impella was placed in the common femoral artery and not below the bifurcation. This is the intervention to the LAD. We wired the lesion with a BMW. The lesion was ballooned with a 4.0 balloon, and then a 4.0 by 16 drug-eluting stent was placed in the proximal RCA. It was then post-dilated with a 4.5 non-compliant balloon, and this is our final result. So for this procedure, we used the Impella-CP. The LAD was wired with a BMW, 4.0 by 12 NC for pre-dilatation. A 4.0 by 16 drug-eluting stent was placed, and then post-dilatation was done with a 4.5 by 12 non-compliant balloon. Then we turned our focus to the left circumflex. The plan was to put a guide liner to the mid-segment of the left circumflex and try with wire escalation to recanalize the chronic total occluded distal left circumflex. We tried several wires without being able to get to the distal left circumflex. However, at some point, we were able to advance to a distal obtuse marginal branch, and we were confident we were in the true lumen. Therefore, we performed a balloon angioplasty and stenting of the proximal segment of the chronic total occlusion with a 3.0 stent. Then we realized that we had the distal segment had created dissection which was present before. Therefore, we tried to re-enter to the true lumen. and advanced it to the distal segment, which was very challenging. We were able to advance with a pilot 200 followed by a turnpike. As you can see here, the wire was getting to the distal obtuse marginal rather than being able to advance to the distal left circumflex. This is the standing of the proximal segment. This is the advancement of the wire to the distal left circumflex. However, we see that we were not in the right vessel. Therefore, we had to rewire the whole vessel. And this is the time where our wire went to the true lumen, and we were able to put a long 3/0 stent more proximally and 2/5 stent in the distal segment of the circumflex. And this is our final result. Therefore, for this intervention, we used the Impella-CP as support. We used Turnpike, Fielder XT, Pilot 200, and Miracle Brothers 3 gram. The Pilot 200 was the one that initially crossed the lesion to the distal obtuse marginal. We used the 3/26 drug-eluting stent. Then the second lesion, Crohn total occlusion, was crossed again with the Pilot 200, and we put a second 3/26 drug-eluting stent. Finally, the last part of the Crohn total occlusion was covered with a 2/5/20 drug-eluting stent. The procedure was complicated by ventricular fibrillation ×2, and the patient recovered without any consequences. The Impella was left in place overnight as we had maximized contrast and radiation, and patient was brought back next morning for intervention of a complex right coronary artery. So the right coronary artery was not only tortuous, diffusely diseased vessel, but most importantly, it was very difficult to cannulate because it had an anomalous anterior takeoff, and the proximal segment was diffusely diseased, unable to get good support. Therefore, we started with a 6 French AL 0.75, and our strategy was wire escalation. We were able to advance a Miracle Brother wire in the mid segment, followed by Turnpike. However, we were not able to advance more distally, as we did not have very good support from our guiding catheter. Therefore, we had multiple attempts to rewire, trying to achieve better support without any success. Here we have advanced our Turnpike and Pilot 200 more distally. However, again, we were not able to advance the true lumen distally. For that reason, in that time, we decided that we needed better support. Therefore, we performed balloon angioplasty of the proximal segment with a 2/0 balloon. And with that, we were able to advance a guideliner to the ostium of the right coronary artery, which gave us enough support to proceed with our PCI. We advanced the Turnpike more distally, and this distal lesion was able to be crossed with initially with a Miracle Brother 3 grams, which was exchanged with a workhorse wire. We performed angioplasty with a 1/5 balloon, 2/0, 2/5, and 3/0 balloon, and we were able to achieve antegrade flow. And then we performed full metal jacal stenting of the RCA, and finally of the ostium of the RCA. And this is the final result of our intervention, TIMI-3 flow. Therefore, we perform we used radial access for the injections in the left coronary artery, and right femoral access for the right coronary artery CTO antegrade. The devices we used were Impella-CP, Turnpike, Fielder XT, Pilot 200, and Miracle Brothers 3. initial angioplasty in the RCA was performed with 1.5 and 2.0 in order to advance the guideliner, and the CTO was finally crossed with, and re-entry was performed with Miracle Brother 3. We ballooned the whole RCA segment, and finally we put a 2.5 by 38 drug-eluting stent distally, 3.0 by 38 mid-segment, and 3.5 by 16 proximally. Thank you very much.